Now, next topic for our next session is fluorescent cholangiography. To chair this session, I would like to invite our chairperson, Dr. Vaibhav Varshney from Jodhpur AIMS. Dr. Vaibhav Varshney pursued his MCH from GV Pant Hospital, New Delhi. And right now, presently, he is associate professor in the Department of Surgical Gastroenterology, AIMS, Jodhpur. He is involved in both laparoscopy as well as the robotic HPB surgeries. Our next esteemed chairperson is Dr. Mukesh Kalla, the senior consultant and director of SR Kalla Hospital, Jaipur. Welcome, sir.
For the next talk on fluorescence cholangiography, I would like to invite Professor Abbe Fingerhut. He is Emeritus Professor in the Department of Surgery, Louisiana, Orleans. He has worked in many universities in Austria, China, and Romania. He is co-author and author of in more than 700 articles. So over to Professor Fingerhut.
Before he starts, Dr. Mukesh Kalla, can you mute? Dr. Mukesh Kalla is online. I request you to unmute yourself. Dr. Kalla? Dr. Fingerhut, do you want us to play your video or you would like to give your talk live? Dr. Fingerhut? I think we can play the video.
Good morning, everybody. It's my privilege today to talk to you about fluorescent cholangiography. In fact, I've been interested in fluorescent-guided surgery for many years. And in collaboration with Professor Luigi from Milan, we have written several papers about the topic and a guide which has been published by Storz. Why use ICG during cholecystectomy? Well, we know that 70 to 80% of bile duct injuries are due to misidentification of the biliary structures. After being a strong proponent of routine intraoperative cholangiography, which we know used routinely does reduce the prevalence and the severity of biliary injuries, it's only successful if the cholangiogram is interpreted correctly. We have to have a full upper bile duct anatomy seen on the screen. All the sectorial and other branches have to be visible. It is just not acceptable to see any failure or have leakage of dye. ICG cholangiography has even been found to be better than the critical view of safety that I will talk about now. The critical view of safety, as you are all aware of, consists of clearance of all fatty tissue from the hepatocystic triangle, freeing the lower third of the gallbladder from the cystic plate, and seeing two and only two structures. However, the critical view of safety is not a preventive measure, in my opinion. First of all, it can be ineffective in case of variant anatomy, severe inflammation, or when the cystic duct is short or hidden, either by a large stone or because of difficulty in retracting the gallbladder. For instance, in the obese or in the wake of acute cholecystitis. Most importantly, it's not always performed correctly. And there sometimes can even be more than two structures. In several publications, the critical view of safety has been reported not to be obtained, either intentionally, because the surgeons do not want to do it or don't see the need to perform it, between 50 and 75%, or unintentionally, in other words, after the surgeon has set out to do it, and then failed to obtain either the critical view of safety or failed to obtain the doublet view, in other words, anterior and posterior inspection of the bile duct structures. So the infrared cholangiography is actually transforming the visualization of the bile duct structures into a visible component by the fluorescence technique that I've just exposed, where we can see the main bile duct structures, the left and the right and the left hepatic ducts, and the cystic duct here. The problem is that you have also the liver that lights up. There's several reasons why I believe that near-infrared cholangiography is better than IOC. It's always possible, whereas IOC depends on several factors that sometimes means that you will not obtain a correct visualization. There is no learning curve. It's faster, quicker to perform an NIR cholangiography than it is an IOC. There's no need to mobilize specific equipment or to have the radiologist or radiology personnel come down to the OR. There is no little need for any dissection before identification. It can be repeated as often as necessary and safely. There's no allergy or adverse reactions that have been identified. There's no radiation involved, so it's safe even in pregnant women. It enables real-time surgery. In other words, we can perform the dissection, the transection, and resection safely in white or in the NIR format. There's no need to look at a different screen. All the information is on the same working screen. And it can be used to identify both the bile duct anatomy and the vascular structures. It makes it an excellent teaching tool. Here we see an example in a case of acute cholecystitis, where dissection is often done without knowing where the structures are. Once the hepatoduodenal ligament has been identified and structures have been, let's say, pushed away, the duodenum essentially, we can have an adequate view of where we are and find that we are indeed on the common bile duct structures, and we can pass from the infrared to the white light to know exactly where we are and how we can envisage the dissection. I said that the technique is possible not only to identify bile duct structures, but also the cystic and hepatic arteries, as you see here. Once you have identified the bile duct structures with a bolus injection, you can identify the hepatic artery, and especially the right hepatic artery, as well as the cystic artery. ICG cholangiography is very cost effective. Obviously, you have to pay for the camera and the light source, but once this is obtained, the price for one vial of ICG is, at least in France, 88 euros, but that same vial can be used for several patients during the same day. Because of the quicker time necessary to execute the investigation, you save OR time. There have been several studies on what is the best dose and the timing. A systematic review a couple of years ago looked at several studies, 27 trials actually, with over 1,000 patients. And most of these studies used 2.5 milligrams administered at less than 1 hour before imaging. Imaging after that was not studied at that time. It has been studied since, and the one recent paper that was published recently in Surgical Endoscopy said that the optimal dosing was 10 milligrams, up to 10 milligrams, and up to 1 hour before, 10 to 12 hours prior to surgery. I'd like to point out that this is misleading, and that the actual dosing and timing that has been put forth by the International Society for Fluorescence Guided Surgery recommends 0.05 milligrams per kilo, or 2.5 milliliters, injected at least 45 minutes before the procedure. Actually, today we've gone down to 0.02 milligrams per kilo. The reasons are that for instance, after an injection of one vial, which contains 25 milligrams diluted with 40 mils of sterile water and not saline, we inject 1.5 mils 40 minutes to 1 hour before surgery, and that same vial can be used for other patients, as I said, because the contents are good for 6 to 8 hours. In this way, and this dosage, the liver is practically not fluorescent, where the bile duct tree is. I'd like to run through 3 publications that have been published recently, one coming from Rome, where I participated in a case match comparison, where we looked at 88 patients, 44 in each group. And here we can see very clearly that the mean operative time was much shorter when we used the inflorescent cholangiography as compared to the traditional intraoperative cholangiography. The conclusions were that fluorescent cholangiography was safe and effective for early recognition of the principal biliary structures. A recently published study out of Korea looked at a way that ICG might help early. Another recently published study in the British Journal of Surgery looked at the use of, or the comparison of fluorescence or X-ray cholangiography in a randomized clinical trial again. The main endpoint here was identification of the critical junction rather than the critical view of safety. And in this study of 120 patients, you can see that the critical junction was not identified. The main endpoint was not identified any quicker or any better. However, the right and the left hepatic ducts were. Whatever means you use, once you have to look at what you have done, think about what you have done, but do not divide before you have an appraisal of what you have done and what you see. This culture of safety is probably one of the most important factors to avoiding bile duct injury. Thank you for your attention.
Thank you, Professor, for the nice talk. Any query from the floor? Any questions?
Oh, that's a very comprehensive presentation of this new technology. Can this technology be interpolated to other like bile leaks for the patients?
Sir, can you repeat the question, sir?
Saying, can this technology be used for, say, patient who has a bile leak?
I think if you have given the ICG and there is a bile leak, it will, you're not able to see the whole area. It stain the whole hilar area and the bile duct. So I think in those cases, it is not feasible to use ICG. It is useful for cases in which we have to identify the biliary anatomy. Is there any anatomical variations? In those cases, it is better. And just to conclude, like this indocyanine green, when we are using for the cholangiography, it is, as sir mentioned, it is always possible. But I think in few cases when there is a thick tissue over the hilum, especially in cholecystitis, acute cholecystitis, and patients who are morbidly obese, and where there is a lot of fat present over that area, in some those cases we may not able to visualize the whole biliary tree, especially the extrahepatic, which we are looking for. But this indocyanine cholangiography is very useful for training purposes. If you have given, when you have seen the critical view of safety, so if by this you can see the whole extrahepatic biliary tree, and you can train our residents that this is the normal thing or the variation that are present. Sir, yes. Correct, sir. Sir, correct, sir. Yes, sir. So it has been seen that when you have given ICG intravenously, the whole liver gives a green image. So the visualization of bile duct is little difficult. After giving ICG in inguinal lymph node, when there is a selective drainage of the ICG in the bile duct, so you see only the biliary tree, not the liver. So that is used in those cases, sir. And sir, as you mentioned, it is systematically assessed that after giving ICG without doing the dissection, you see less of the junction cystic duct and the bile duct. As you dissect further, you will able to see whole cystic duct and the common hepatic and the common bile duct. So as you progress further, the visualization is better and better. Correct, sir. Sir, you have to use give ICG at least 1 hour before, like at the time of induction of the anesthesia.
If you do it very early, then the liver lights up too brightly. If you give it time, then it starts getting excreted, and then you can see the biliary anatomy better.
It takes at least 45 minutes to come in the bile
minimum
duct, sir.
45 minutes.
45
You
minutes, yes,
can
sir.
see the biliary anatomy very well. But again,
Background. Correct, sir. And basically it is like if you are doing some choledochal cyst, sir, and you have given an ICG, you can see any biliary variation, because in those cases you may found like sectoral duct entering lower down the hilum. In those cases, it is very helpful to divide at what level you have to transact the upper level of choledochal cyst. This is one more use. ICG fluorescence. And there is one question. Any contraindication to ICG? No. As it is, we have not found any allergic reaction to indocyanine green. It is very safe, and it can, as sir mentioned, we can give in pregnant women also. So it is very useful. the thing is coming up, and for that you need specialized laparoscopic towers. I think at present all major companies like Carl Stores have Rubina system, Stryker has 1688 AIM system, and Olympus also have a ICG system. So they have also different modes. One is overlay mode. In this, you will see the normal tissue as it is, as it looks, and on that image you will see that bile duct flourishing over it. There are other images like monochromatic phase and some phase in which you see the color changing. It's becoming green, it's becoming blue, and as the dye passes off. Sir, any questions, sir? Yes. Sir.
It delineates the bile duct and the cystic duct. The question is, in very difficult cases, frozen cannot find it. And if you say that it is better delineated when you have done some dissection. The issue will occur when that dissection is being done. And more so, even if this facility is provided in periphery, where the chances of injuries are more in hands of the inexperienced surgeon, and the setting is not as good as these very highly specialized centers, how much good it is that this ICG will prevent the injury in those peripheral setup.
Correct, sir. Sir, for your second question, first, for using a ICG, you need a specialized tower, sir. So if in a peripheral center, this laparoscopic tower is not, facility is not available, you cannot use it. Now, sir, as sir mentioned, you have to dissect some tissue over that hilum or over that callus area to visualize exactly where is the bile duct. If you are not able to see, this ICG has limitation in those cases. So in those cases, IOC is helpful if you have to look especially where the bile duct is present.
IOC also same thing. What here? Because IOC, what I think General Atul Sharma told, that if you, you can do too many things. Theoretically, they are all right, but the amount of dye you have to put contrast, you have to put into the gallbladder to visualize the already very deformed anatomy. I don't know how many things. Because after all, when I was an MS student and and after that, when I was general surgeon, I think I might have done 3-4 intraoperative in open cholecystectomy cholangiogram. But once we started laparoscopy, I don't think we have done any. So all these centers, because I was trained in already Institute of Medical Sciences, and thereafter I have worked in some very high volume centers in the armed forces. We ourselves were not convinced, and that is why this IOC has, debates is on ever since, but it has gone out of vogue only because in all these centers, people were not very convinced about the utility and the time and effort it goes into doing that procedure. Same thing, like this ICG, the availability, fluoroscopy is not available, that special type of a table, it should have that glass top. So all those things.
Your point is well taken, but sir, for doing any investigation, as sir mentioned, if you have to find any violent injury, you have to do in all cases. You have to practice it. You have to make your resident learn. That's why the similarly go to ICG. If you have to practice, you need specialized laparoscopic tower. You need drug, so that you can. If you do 100 cases, you will be able to identify in 1 or 2 cases. So you have to practice regularly to identify, or you have to you will not be able to miss any violent injury in those cases. That is basically fundamental of all these investigations, IOC as well as fluorescence cholangiography, that you do routinely, so that you get a proper image how it looks like, so that you can identify biliary anatomy and you can prevent them from injury. Sir, Dr. Mukesh Kalla, sir, do you want to ask any question?
Yeah, no, I think it's a very quite a comprehensive assessment of the situation. Reasonably well informed on the subject.
Thank you, sir. We can conclude the session.
Thank you. Thank you,
I think.
Dr. Abby Fingerhut, for the illustrative lecture for ICG. I think I am completely agree with Dr. Vaibhav's comment that if we want to masterize in ICG, then we have to involve this thing in our day-to-day practice. Then only we can learn, and the most important thing for ICG is the dose, the amount, and as well as the timing. Thank you, Dr. Vaibhav, for your nice comments and chairing the session. Thank you, Dr. Mukesh Kalla, for chairing the session. The topic for next